Uh, okay, so before I open discussion, I have some very important stakeholders in the battle against hepatitis. Can I have my presentation on? The one you displayed. And these are the HCV diagnostics. So we have representation from Abbott. Is a representative from Abbott here? Yes. Okay, so I'm leaving 4 questions here, which I would like to comment on. We have Abbott, Roche, and Gene Expert. So what they have to say about penetration in Pakistan, output in terms of results and cost. Can we just take the mic there? Who is going to speak on behalf of Abbott? Yeah, there in the middle. So output in terms of results and cost, and how can we help for public benefit? Any suggestion you have for us? If you can please introduce yourself and then.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. My name is Sarmat Bhatt. I am working in Abbott as a business manager. Our capability in Abbott is that we have almost every products from screening to cure. Like we have SD Bioline for rapid tests, and we have a history in Egypt to successfully established our penetration over there. We also have history of success in Africa with the rapid diagnostics, and in the resource where there is a less resource settings and affordability is the issue, we have HCV Core and Genome Architect, and we have a penetration all over Pakistan. And then in PCR we have 2 platforms like M2000 and Alinity M. So we have 35 installations all over Pakistan, and all those installations can perform up to 4 million tests per year. So you can visualize the scalability we have and the penetration, and our products are 6 Sigma approved as well. So the quality is the best in class. And about the costing, we can say that we have reduced our price to almost 100% for the last 3 years, looking into the AUP and then exchange rate factors, because we want every patient to get tested so that the treatment can be placed. So we are ready to further invest wherever it is possible. That is our social responsibility, and we are committed to this. Thank you.
Thank you. Can I know the lowest PCR cost for hepatitis C that you can offer, because there are a lot of private organizations, NGOs, representatives here, and at what volume that suits, that will be mutually beneficial for both of us?
Actually, it is very good question, and all is depend upon the business feasibility. You know, we have the large scale, high throughput instruments, and the instrument cost is almost approximately $500,000 per box. So we have to calculate the volumes. So it totally depends upon the business model and the volumes that you give to us, and then we can calculate on the basis of volumes and as well as the project. So the price actually we can't say without the volume, but it will totally depend upon the collaboration and partnership. I can roughly say that we were selling our HCV PCR $25 in 2019, and now we are selling laboratories approximately $13 to $15. So we brought down the cost to half without compromising quality.
Okay, thank you. We have a Roche representative here. Yes. Again, if you can introduce yourself, I have similar set of questions. Thank you very much for coming and joining us here.
Assalamu alaikum. Thank you very much, Rosa. My name is Maqsood Ahmed Khan. I am working as a Director of Market Access in Roche, Pakistan. And it's my privilege. Thank you very much to invite and I thankful to management of PSH for giving us the opportunity to speak here. We believe that HCV elimination is our national responsibility, and no one can do it alone, and not a single formula can fit to all. In my opinion, we should adopt hybrid model and involve all major stakeholders for initial screening and for viral load testing. As far as Roche solution is concerned, we have two different systems. One is a low throughput system for low settings, and second, the medium throughput system. These two systems are installed in Pakistan, and we have 56 current installation, completely automation in 8 cities. But very soon, in the first quarter of 2023, it will be increased, and the cities will be increased from 8 to 20, 24, and the system will be almost around 80. So our low throughput system can perform 144 tests on a single day. And if you calculate its performance on a year to 43,000 tests, a low throughput system is able to perform. And for 8 years, 345 tests can be performed on a single system in 8 years. So we can say 20 system can perform 6.9 million tests in 8 years. This is about the low throughput system. The second system is the medium throughput system, which is already using in the Punjab Hepatitis Control Program, which is C6800. And this system can able to perform 384 tests in 8 hours. And at the same calculation, only 15 systems is able to perform 13.8 viral load in 8 years. So we have a good systems, and already we are working with Sindh Hepatitis Control Program as well as Punjab Hepatitis Control Program from since many years. As far as the cost related question is concerned, we are already committed with the WHO globally commitment gap prices, and we are ready to apply these prices in Pakistan whenever and whatever is required. Yes, my colleague from Abbott said it depends on the volume, but you know, if elimination is concerned, then definitely we should play a different role to eliminate Hep C from Pakistan. Thank you very much.
Thank you very much. We have all heard about Gene Expert, and Egypt used Gene Expert very effectively, and we have a representative from Gene Expert. Yes, please. If you can kindly introduce yourself here. So what stops Gene Expert in Pakistan? It's not been that good. Thank you very much for coming.
Assalamu alaikum everybody. My name is Zafar Mahmood. I am CEO of Global Marketing Services Pakistan, distributor of Safed for Pakistan. I would like to share here that of course this is our national dilemma, national crisis, and we should all work together to achieve the target by 2030 to have a zero hepatitis C in Pakistan and to eradicate it fully. We appreciate the effort of PSH, and I would like to share very happily that we are the first company who have also started the local manufacturing of rapid testing line in Pakistan, and it has been registered by DRAP, and soon this will be available. So the national capacity for the development of the rapid test will be available. At the same time, Gene Expert technology is very unique, and everybody knows that this use finger pricking testing, and this will be available as a point of care testing using the cartridge, stable at the room temperature, and it can be used in the far off and the remote areas for rapid testing as a rapid PCR testing result within 90 minutes. As it has been highlighted repeatedly here, that retesting and of course testing and retesting as well as to have the patient at the same time to start the treatment. So I think Gene Expert is one of the choice for the remote areas as well as for the rapid PCR testing. And we are also discussing, as Dr. Tariq shared, that we can align with Safed to start some local manufacturing if we develop and expand this program and to develop the local capacity and expand to the remote areas. As Gene Expert has been widely used for the TB diagnosis in Pakistan, more than 600 devices are available across the country in almost every district and tehsil level. So probably this might be a very effective, it might be a cost-effective solution in the long run because of the availability and because of the supply chain issues and the other temperature issues and the storage issues. But we can negotiate, and the Gene Expert is also part of the Global Fund program. So we can have the same price level, and we can even negotiate with Cepheid as a manufacturer to bring this technology in Pakistan. And this is because of the TB and hepatitis C. These are the two main burdens of our country. So this might be a very, very, I think, cost-effective solution. And we are open to expand, and we are open to negotiate, and we are open to, of course, extend our support to achieve this national objective to eliminate hepatitis C from Pakistan.
Thank you.
Thank you.
Thank you very much. We are also fortunate to have some key stakeholders who run NGOs across Pakistan. This is a unique moment. I mean, if you have any comments on this, any suggestions, I can assure you on behalf of Pakistan Society of Hepatology, we are going to take matters further, and we have a very expert panel and the people who matter. We also have hepatitis control program directors from Sindh, KP and Balochistan present here. So they are listening. We are going to talk to them and we are going to take things forward. Unfortunately, Punjab hepatitis control program director had an emergency. He had to rush to Multan, so he couldn't join us today. So any comments from some quick points, and I'll go to the expert panel to conclude the session. If you can raise your hand, if you have any suggestion. Yes. If you can introduce yourself. And then.
Yes, my name is Dr. Bilal Ahmed. I am liver transplant surgeon from GIMS. I am just giving a small suggestion, like we just go through this COVID era, and we have, we very wonderfully have controlled the COVID. So I was just want to give one small suggestion. Why not we follow it HCV like COVID and make it compulsory on our CNIC whenever anyone goes for CNIC issuance. We should, we should make it compulsory. Everyone who makes CNIC, they should go with HBV and HCV testing. And instead of government should pay the payment, we make this at the amount of test. We should add it on the CNIC documentation charges. And in this way, the burden will not be on the patient also. Like the government, it will not be on this what I want to say, the burden will not be on the government also, and the patient will, he will be like thinking, I am only paying for the CNIC, and in this way we can have a, screening of all the population in Pakistan.
Okay, thank you. Any other suggestion? We have, because this is the time that, okay. If you can just introduce yourself, and can I have a mic here, please? Thank you.
I'm Dr. Ijaz Ahmed I am a practicing physician in Mandi Baudin. My concern is that there is little discussed about the prevention. Means quackery is the main culprit behind this all propagation of hepatitis C. So with Healthcare Commission, and we should formulate some method to for the prevention of hepatitis C.
Thank you. Thank you. Just go towards the panel of experts if you have comments and suggestions and looking at way forward. Professor Anwar, please.
Thank you very much. It was a very nice, illuminative session. I have a question from Graham. Initially, I was kind of heartbroken when you said that we cannot really meet the goal by 2030 in Pakistan. But you gave us a good news that although we do not meet the goal, we still are good enough to cure majority of our patients, save them from HCC, and prevent them from coming to the hospital more frequently. So that was a very encouraging comment, so that we keep working on it. We don't stop because we cannot meet the goal. So I think that's a very good message we should all go home with, that our efforts, whatever it is at the government level and at the private sector level, it should continue and expand, so that we keep the goal in mind, 80%, maybe 60, 70%, but we will get majority of our intentions of getting hepatitis C as a main curse in Pakistan, to get rid of it. Thank you. So the other comment, I would like to have opinion maybe of Huma and Dr. Yas, that we hear so much about the Egyptian model, that you take the treatment to people's home and not have them come to your centers, because there are so many logistic problems, cost, transportation, and all the means. So is that model effective in Pakistan? Can we sort of give suggestion to at the government level that yes, maybe we should have ambulances, we should have vehicles to take the team to the people, test and treat at the same time, at their home. So maybe this is just a thought. Maybe they can expand on it. Thank you.
Dr. Gyas?
I think it's a very important issue, taking the treatment to the home of the people. In Punjab, we have been practicing it. We have been giving treatment for 3 months as a bundle and sending them on their address. But what has been the outcome? Since initially it was COVID and then later on there have been floods, so we are not really sure about the impact of that in terms of real translation to a sustained biological response. But yes, this has been worked on, and we did practice on this pattern. But more importantly, I think if we want to make this program successful, we need a very strong political and administrative backing. And unless we have a very strong political and administrative backing, this aim of eliminating hepatitis C by 2030 may not be that realistic. And for that, I think on this platform and the people who are sitting here, they all have connection, they all have their voice. We need to reach out to the relevant quarters to bring back the kind of advocacy which was there in 2017, 2018, so that we may be able to go forward in achieving this target of eliminate hepatitis C by 2030.
Thank you. Huma, if you have.
Okay, thank you. Professor Anwar, the program that we have put in the National Action Plan is that the tests, the rapid tests are done at the community level, at the RHC or a BHU, so that the patients don't move. And then those who are found positive, reflexly their blood is taken for the PCR and other tests, and then the blood moves, the patient does not move. And then electronically the results come back to this community site, and the treatments are also available there at this site. So the patient does not move, and that's where we think that if otherwise, the patients are lost. If you send them for further testing to a district or a tehsil hospital, they're lost. And same is the case for the treatments. The plan is that, the treatments would be placed at the community level where they get tested, so that they don't have to move very much. And because we are using very simple standard, APRI scores for deciding the duration of therapy, so even, once the PCR is done, the lab will calculate the APRI and send the report along with the APRI to the site, so that all the site, nurse or a technician has to do is to dispense that 12 weeks or a 24 weeks, depending upon. And as it is, 24 weeks treatment is to be done by the specialist, because we don't want the GPs and the healthcare providers to do that. So, but 80% of the population we have calculated would need only 12 weeks of treatment. So that can be dispensed there and then by these nurses and the paramedics.
Thank
So
you.
that's the plan that we have put in. Yeah.
Thank you. I'll have a comment from Professor Hashmi Saab and then go over to Graham Foster.
Thank you very much, Asad. Would like to comment on what Dr. Huma and Professor Riaz were saying, and thereafter I would bring forward another issue. We are working on a much smaller scale. Our trust has 2 mobile units, and we take the point of care to the doorstep of the patients. We take those mobile units with our team to the villages, take the sample. Those who are positive, we take further sample for the baseline and PCRs and all that. And those whom we decide ultimately to put on treatment, the team goes back to the village, gives them the treatment, and takes the sample for further follow-up, investigations and all that. This certainly is far more successful as compared to what we were previously experiencing, requesting patients to come to our center, offering free investigations and free treatment. But even with this effort, trust me, not more than 70% odd patients would come for the final PCR. There is some degree of unwillingness on part of the patients. And it could be for economic reasons, it could be because the disease earlier on being asymptomatic, it may be because health is not a preference in certain segments of our society. And I think it is debatable. This is just one comment. My apologies to Professor Riaz and Dr. Huma, they being the national and provincial leaders. But I was just going through a kind of a report which was published earlier this year, based on the experience for 4 years of screening, investigating and treating patients with hepatitis C. The government spent about 4 billion rupees on the program during these 4 years. And earlier it was estimated by the statistician that at least in Punjab, we need to treat 800,000 plus patients every year to be able to reach the goal of eliminating C by 2030. But what we could achieve with all the centers and all the effort was some 63,000 patients each year, meaning thereby 8% of those who had to be treated every year. So the point I am going to make at this stage is that the problem is huge. Trust me, the effort is proportionately very small. But very luckily, we belong to a society where people are very conscious of their social responsibilities. And they come forward to join hands with medical professionals, government and others. And we have all seen it on different occasions. I strongly believe, as has been mentioned by one of the speakers, it's high time for private-public collaboration. Trust me, it would pool the resources, it would pool the wisdom, it would pool everything. And we can then and only then overcome this issue. I don't believe that we have the required political commitment. I don't believe in it. My trust has been a victim of it, without going into details of it. The political commitment is inadequate. We need to move forward. We need a kind of legislation. We need to know the responsibilities of the government and the responsibilities of the public, private sector. Then and only then we can move ahead. We have a common enemy, and I think we should have proper strategies. All stakeholders should join hands, not just the NGOs, by sharing their experiences, their difficulties. The societies, as has already been pointed out, that, the Pakistan Society of Hepatology, the Gastroenterology Society, so many wise people all around. And then with their input, we can come up with a far better strategy. Great, we talked about the Egyptian model, we talked about so many other models, but I assume, like with most of the other diseases, different areas of the world, the regions, they have different dynamics. We can take some points out of them, but then jointly when we discuss it out, we can find out a far better answer. I thank you once again for giving me this opportunity, and my apologies.
Thank you.
Thank you so much.
Thank you. Graham?
I think you've identified the challenges, but you have also taken the first steps to addressing those challenges. And I think Pakistan is on a road that will eventually lead to elimination. And if it's not 2030, if it's 2033, 2035, that's fine, because people will be getting better all the time. So I think Pakistan is in the right direction. I think you all understand it needs to go up a gear. I have to say, I'd love to get your politicians involved, but my experience of politicians is it's a waste of time and energy. But I do think that the collective medical voice, working with the community, working with local people who want to make a difference, and with the pharmaceutical industry and the diagnostic industries, you have here the bones of a very powerful program, and you've already made big strides. So I don't see any reason at all why you shouldn't do it. You won't do it the Egyptian way because you're Pakistan, you're not Egypt. And of course you will evolve. But I always look at Huma's original study. You know more about hepatitis C in Pakistan than I do about hepatitis C in England. You have better models, you have better data. You've made very strong progress to getting started. It's now moving forward post-COVID into the final phase. And I think you will do it. Every time I come to Pakistan, you've made another step forward. I remember when I first came, the blood transfusions, only 30% were being tested for hepatitis C. That's not the case anymore. You got rid of major routes of transmission. You're making big strides to prevention, and treatment is ramping up. So I'm very optimistic. I think you will do it, and I think I will be here to see it.
Sure. Thank you. Thank you. Can I have my presentation back? So thank you very much. Just remain seated. Can I have my presentation back on? अभी आपको खाना नहीं मिलेगा, फिक्र ना करें. Okay, so I just there's a few in conclusion, so we know that we have adequate information available on hepatitis situation in Pakistan. The technical advisory group hepatitis has been very instrumental in developing the testing and treatment guidelines, hepatitis B treatment guideline, prevention of mother to child transmission of hepatitis B, and training materials for the health workforce. We are all done with this stuff. The Federal Ministry of Health has developed a national HCV elimination program and calculated its cost, HR and training needs till the district level for all provinces. It is time to act now, and provinces should start either by taking the whole province or go by high prevalence district. We need to engage private sector, CSOs, NGOs as partners to reach out the population. Use electronic data entry at all levels to get real-time data. Engage ECHO for distant training and consultation for distant cases. So from now, I would just request the chairs to be seated, and I'll request Dr. Bushra. So she'll now stand from Lahore in between you and the dinner. So Bushra.